welcome. My name is Jeff Resnick. I'm Chief of the History of Medicine Division here at the National Library of Medicine. Thank you for joining us today, those of you here in the Lister Hill Auditorium and those of you watching remotely. Today we're going to be hearing the 10th Annual James H. Cassedy Memorial Lecture in the History of Medicine, which is part of the NLM's 2018 History of Medicine Lecture Series. Now, for the past decade, the NLM's History of Medicine Division has hosted this special lecture in memory of our late colleague, Dr. James H. Cassedy, renowned historian of medicine, 50-year employee of NLM, editor of the printed bibliography of the history of medicine, and a bibliographer for the HistLine database. And these are all have been essential tools valued by countless scholars over many decades. During the course of his distinguished scholarly career, Dr. Cassedy received every major honor that the National Professional Society in his field could bestow. That is, of course, the American Association for the History of Medicine. In addition to the Welch Medal, which he received for his books, American Medicine and Statistical Thinking, 1800 to 1860, which was published in 1984, and his book, Medicine and American Growth, from 1800 to 1860, published in 86, Dr. Cassedy was awarded the Association's Lifetime Achievement Award and delivered its honorary Garrison Lecture as well. He also served as president of the association from 82 to 84, and he worked on many of its important committees on behalf of the profession. It's an honor for me today to introduce our colleague, Dr. David Jones of Harvard University, who will be giving today's Cassedy Lecture. Dr. Jones is the A. Bernard Ackerman Professor of the Culture of Medicine in the Faculty of Arts and Sciences and Faculty of Medicine at Harvard. Dr. Jones received his PhD and MD degrees from Harvard University, both in 2001, the former in the history of science. After an internship in pediatrics at Children's Hospital and Boston Medical Center, he trained as a psychiatrist at Massachusetts General Hospital and McLean Hospital, and then worked for 2 years as a staff psychiatrist in the Psychiatric Emergency Service at Cambridge Hospital. Dr. Jones joined the faculty at MIT in 2005 as an assistant professor of the history and culture of science and technology. And from 2004 to 2008, Dr. Jones directed the Center for the Study of Diversity in Science, Technology, and Medicine at MIT. There, he organized a successful series of conferences about race, science, and technology. And in 2009, he was appointed as the McVicker Faculty Fellow, MIT's highest honor for faculty who've made sustained contributions to undergraduate education. Dr. Jones also taught as a lecturer in the Department of Global Health and Social Medicine at Harvard Medical School, where he was awarded the 2010 Donald O'Hara Faculty Prize for Excellence in Teaching. In 2011, he left MIT to join the Harvard faculty full-time as the inaugural A. Bernard Ackerman Professor of the Culture of Medicine, a joint position between the Faculty of Arts and Sciences and the Faculty of Medicine. The Ackerman program at Harvard University fosters collaborations in the medical humanities and social sciences across both campuses. Dr. Jones' initial research focused on epidemics among American Indians, resulting in a book, Rationalizing Epidemics, Meanings and Uses of American Indian Mortality since 1600, published by Harvard University Press in 2004, as well as several articles. He's also examined human subjects research, Cold War medicine, HIV, and other sexually transmitted infections, and the history of cardiac surgery. His current research explores the history of decision-making in cardiac therapeutics, attempting to understand how cardiologists and cardiac surgeons implement new technologies of cardiac revascularization. This research is supported by an investigator award in health policy research from the Robert Wood Johnson Foundation for Informed Medical Decision-Making, and also by the National Science Foundation. The first book from this work that Dr. Jones has been doing is entitled Broken Hearts, The Tangled History of Cardiac Care, published by Johns Hopkins Press in 2013, and it examines why it can be so very difficult for physicians to determine the efficacy and safety of their treatments. Dr. Jones is now at work on 2 follow-up books, one entitled On the Origin of Therapies, which will trace the evolution of coronary artery bypass surgery, and the other on the history of heart disease and cardiac therapeutics in India. Through his extensive historical research over the past several years on these topics and others, Dr. Jones has developed and articulated a profound appreciation for the value of historical content in medical education curricula, a philosophy that he will share with us today. Please join me in welcoming Dr. David Jones to the National Library of Medicine to deliver this year's James H. Cassedy Lecture on this important subject, one that interested Dr. Cassedy as well, making the case for history and medical education. Thank you.
I'd like to thank Jeff and the staff at the National Library of Medicine for the invitation to come speak with you here today. I'm a big fan of the National Library of Medicine for several reasons, both because I've received a grant from the library which funds part of my research, and second, because the library has maintained its commitment to keeping and curating very well one of the most valuable collections for materials in the history of medicine any place in the world. I've now spent 2 days this week happily ensconced in the library reading room, getting my hands on material that is relevant for my work in India. It turns out National Library of Medicine has much better collections of Indian hospital annual reports, journals, bulletins than those institutions themselves in India have. So if you're doing the research on history of medicine in India, you're much better off coming here to Washington than actually going to India to do the work itself. When I was preparing my slides over the weekend in advance of this talk, my son, who's now in 10th grade, was looking over my shoulder. And when he saw the title, he said, "Dad, why are you going down to Washington to ask them not to take your job away? Why do you have to defend the importance of history of medicine?" And so I explained that fortunately I didn't think my job was at stake in this talk, but I actually think that something much more important is at stake. And this will sound like a surprising claim coming from a historian, but that's actually what I think is at stake is the quality of healthcare and the resulting health of patients. And I will attempt to convince you that both of these things could be improved if people who are practicing medicine and healthcare had a better understanding of the history of their field. And so if you were to ask the broadest question, does the history of medicine matter? You quickly realize that this is a question that physicians have been arguing about literally for thousands of years. You can find arguments about the history of the profession going back to Galen, if not before. And despite that, it's something that most physicians in their daily work today do not spend much time thinking about history in any meaningful way. If you were to ask a much more specific question, does history of medicine matter enough to be included as an important part of medical education? Again, what you would realize is that for most of the history of medicine, not just in the European tradition, but in most East Asian and many other medical systems as well, medical education was the history of medicine. If you wanted to learn the practice of Western medicine or traditional Chinese medicine, what you would do is you would study classical medical texts, and that's how you would learn diagnosis and therapeutics. Now, obviously, much has changed, and as I'll explain, over the 19th and the 20th century, history has lost considerable ground from this high point in this role in medical education. In 2008, the American Association for the History of Medicine surveyed 174 medical schools in the United States and Canada and found that 98 of them had no indication of history anywhere in their curriculum. Another 19 likely didn't have any, but they just couldn't verify that from the information that was available. And of the 51 that did have some indication of history in the curriculum, it was hard to find any information about what was actually involved and whether this curriculum was at all useful. So given this compromised state of history of medicine in the early 21st century, historians have been quite interested to notice what has happened in the field of popular publishing, which is that 2 works in the history of medicine became runaway bestsellers over the past 10 years, one of which won the Pulitzer Prize. Of course, historians were quite chagrined to admit that neither of these works was written by a historian of medicine. One was written by an oncologist, and one was written by a journalist. But it was clear that the general public thinks there's something interesting and valuable to learn from reading or at least purchasing these books about the history of medicine. And historians, especially historians who, like myself who work on therapeutics, have also been curious and interested in seeing over the past decade or so a series of discarded medical treatments from the early 20th century have been revived in particular therapeutic contexts. As I'll explain towards the end, I think sometimes for better, sometimes for worse. And so for a variety of reasons, in particular eras, doctors have recently begun to turn back to past therapeutics, discarded therapeutics, in search for possible therapeutic innovation. And then the last place where you can see history of medicine alive and well and very much at work has been in the recent debates about healthcare policy. And I'm trying to remember exactly what year it was. I think this was in the winter of 2011 or 2012. I had the good fortune to have as a guest lecturer in my class Larry Summers, who was just back in Cambridge after 2 years as chairman of Obama's Council of Economic Advisors. And he was talking about the inside scoop on the prospects for the Affordable Care Act. So he was laying out the strategy as seen from within the White House. And he said that everyone involved knew that the law was at risk because it had been pushed through Congress in such an unusual way. But they knew well what had happened with the history of Medicare in the late 1960s, which had similarly been a contested piece of legislation when it went through. They knew that within several years, the public had become quite enamored with Medicare. Once you give people health care, they resist having it taken away. And so the entire White House strategy in those first few years was to keep the Obamacare alive long enough that if the Republicans did regain control of everything, which they have, the public would resist having it taken away. And at least so far, that seems to have been exactly what happened. So there are all these cases where people are making good use of the history of medicine, and yet it had largely disappeared from any kind of role in medical schools. So today I want to explore this in more detail, to explore the obstacles and some of the opportunities. Part of this involves a quick review of the role of history in the history of medicine. And then I want to talk about a conference that I hosted in Cambridge in 2013, where I brought together faculty who are teaching history of medicine at medical schools in North America for a brainstorming session, which in many ways emulated a conference that had been hosted at the National Library of Medicine in 1966, almost now 50 years ago. And what I'll describe is that the participants in this conference emerged convinced that history can and should be considered an essential component of medical knowledge, reasoning, and practice, just like anatomy, biochemistry, physiology, or any of the other basic medical sciences. That historical analysis can offer essential insights into our understanding of disease, of therapeutics, and of healthcare institutions, and these are things that physicians must understand if we're going to have healthcare systems that work as well as possible. So again, I suspect some people will be skeptical of that claim, but let me try to convince you. Now, for centuries, physicians had turned to history to learn pragmatic medical knowledge. René Laennec, who's often heralded as one of the first great modern medical pioneers for his development of a stethoscope as a diagnostic tool, wrote his own 1804 medical school thesis on the continuing relevance of Hippocrates to medical practice. So as recently as the early 19th century, famous physicians, innovative physicians, were still turning to the past as their source of innovative medical knowledge, or of relevant medical knowledge. Much of this changed in the mid to late 19th century as medical science increasingly turned away from history and towards the laboratories as the source of new knowledge. That you'll have people like Pasteur and Robert Koch shown here, who become the heroes of a new form of medical practice. And of course, most of the work that takes place at National Institutes of Health is very much in the tradition of Pasteur and Koch, that turn to basic medical sciences in order to make discoveries that will be therapeutically useful. I'm not critiquing this approach. Obviously, it's been immensely productive. Healthcare is much better now than it was in 1870. No one is going to argue that point. But what happened was that physicians turned away from these ancient texts and turned towards new laboratory knowledge as the source of future progress. And in fact, these scientists began to use history as a foil. And what you see, and especially in the early 20th century, is people publishing contrasts between the wonders of new medical science as compared to the awful things that used to happen in the past. So the historical medical practice became the whipping boy against which modern medical science was contrasted. And you can still see this. If you look at popular medical writing now, every year or so a new book comes out that, the 10 most outrageous things that past doctors used to do. And there's enough of a market for these books that they often get reviewed in the New York Times and they sell pretty well, even though many scores of these books have been published previously. There's nothing innovative about making fun of what doctors have done in the past. Now, as practicing physicians turned towards the laboratory and away from history, people who were interested in history of medicine had to come up with new ways to defend the relevance of their passion for history. William Osler was one of the most famous proponents of the importance of history in medical practice at the time. One of his colleagues at Hopkins, Eugene Cordell, who was president of the Johns Hopkins Historical Club, crafted a careful essay in 1904 where he laid out a whole series of arguments on behalf of the potential contributions that history could make. You can read them here, but the highlights are, he said, you can study history to understand what it is that we should investigate, that historical insight was the best knowledge against egotism, error, and despondency, because it teaches us that much of what we have been confident in the past, we no longer believe, and therefore we need to have, that he saw this as an antidote to hubris. If you recognize that past people had made errors, you'll be more likely to recognize the errors that we are all likely making now. He believed that potentially that history could be mined for overlooked discoveries that would have value. Again, something that you still see going on at present. And he also saw an important role of historical teaching to foster a sense of professionalism and professional pride in medical students. The basic idea here was you would teach medical students about these wonderful, honorable physicians who worked at that past, and that would instill in the students some sense of the greatness and the worth of the profession, and then they would behave better. Convinced of the essential importance of history of medicine, Cordell believed that history of medicine should be required at every medical school and taught as thoroughly as any other subject. You had to have required courses with at least 16 or 20 lectures. And he looked forward to the day when the quality of medical school would be determined by the quality of its historical teaching. Now, if you actually look at the content of what Cordell was recommending, what he really wanted was people to be taught a survey of the history of medicine in the Western tradition, going back from the ancient Greeks and following through to the present. And he convinced it was that kind of survey of historical knowledge that would provide this essential value for medical students. Now, obviously, his vision did not come to fruition. I'm not aware of any medical school in North America that is judged by the quality of its history of medicine teaching. They're judged by many other factors instead. But despite that, his arguments continued to be made throughout the 20th century. And so you can go through literally decade by decade and find prominent medical educators making a case for history that was often quite reminiscent of the case that Cordell had made in 1904. So before World War II, you can see work by the leading historians of medicine, Henry Sigerest and Erwin Ackernecht, making the case for the history of medicine. They both favored the argument that historical knowledge would provide invaluable perspective on current practice. Then in June 1966, the Macy Foundation and the National Library of Medicine hosted a workshop here at the National Library of Medicine. They brought together faculty from a range of different institutions, people who taught at medical schools, people who taught more generally at faculties of arts and sciences, senior people in the field, very young people at the field at that time, including James Cassedy. He wasn't at National Library of Medicine yet. He was working for NIH in Paris, but was interested. He came back for the conference and contributed actively. And the person who was given the task of most thoroughly articulating the value of history of medicine for medical education was George Rosen, a very prominent historian of public health. And again, the arguments he makes are reminiscent of the arguments that are made by Cordell. By tracing the history, you could get a sense of how medical knowledge has developed, the continuities between past and present. You recognize that medical knowledge is always changing, something that will make you more open to the change that you will experience throughout your career. It revealed the origins and then, as a result, the contingency of the ideals and values that doctors and patients hold, which is important to understand. He thought, again, it would give you valuable perspective when you'd realize how enthusiastic doctors had been in the past for treatments that were eventually discarded. That would color how you would think about the enthusiasms, as he said, the fads and modish trends that afflicted medicine in the 1960s. And again, that it could foster a sense of professionalism in its students. Now, as you can see, the conference produced a book that has not just the talks that were presented, but also transcripts of the discussions that took place at this workshop at NLM back in 1966. And as you can see, that if you look through, there was vigorous debate about almost every aspect of Rosen's presentation. People argued whether or not history should be a required part of medical education. Could it be required? If it were required, what content would you teach? There was very little consensus about any of these areas. And then again, these calls have continued in the generation since 1966. Historians and physicians, also people who are trained as both physicians and historians, continue to push the case. Joel Howell, who's at University of Michigan, emphasized the ways in which history can help you understand the contingency of medical knowledge and the fundamentally social nature of the medical enterprise. Jacqueline Duffin, a historian at Queen's University in Canada, emphasizes using history to teach humility towards physicians so that to make them more willing to understand the fallibility of medical practice. Baron Lerner, who's now at New York University, argued that history would teach that scientific knowledge is not objective, but it's a function of a particular historical time and place, that social and cultural factors influence both medical knowledge and medical practice, and that the practice of medicine consists of humanistic interactions between clinicians and patients, and thus should be conducted with dignity, respect, and compassion. And these are just 3 examples of literally scores of articles where you have people who are frustrated by the low representation of history at medical schools making the case to increase it. And this isn't an exhaustive list, and many other claims do get made, but there's a striking constancy to the core arguments over time that really goes back to Cordell in 1904. And the basic argument of all of them is that by teaching people history, you can inculcate an attitude towards medical knowledge and practice. So it's not the historical knowledge itself that's important. It's using history to inculcate an attitude towards scientific medical knowledge and practice. Again, by revealing contingency, it will foster an openness to change. And there was also always an interest in the humane and professional aspects of medicine. By teaching history, it rehumanizes medicine in the face of scientific reductionism and demonstrates that medicine is fundamentally a social encounter between humans, each embedded in particular social, economic, and political context. And it also played a role by helping to socialize students into the profession. One of the things that first-year students often realize very quickly is that they are entering a profession that will have an impact on many aspects of their life, how they are considered in society, the choices that they make, how they interact with other people. And often students will just stumble across this along the way. Historians have realized you could teach students to recognize this as in a self-conscious way, and that can help ease the transition into the profession, and also, in a way, immunize them against some of the undesirable aspects of the socialization that medical students encounter. Now, as historians were developing these arguments for history of medicine, they also recognized the many obstacles that history of medicine faced in medical schools. And again, there has been a striking constancy in these obstacles over time. So William Osler complained in 1902 that the problem was just that the medical school curriculum had just become too crowded. There had been too much discovery in the past generation, and all this new medical knowledge that existed in 1902 had made less room for things like history. And of course, that problem is much, much worse now than it was in 1902. Cordell bemoaned the loss of interest in history. He thought that everyone in the early 20th century was much too carried away with novelty. Everything that was new was good. Everything that was old was not good. And this was the problem. And again, you can see traces of this alive and well today. Henry Sigerist, with a wise observer of institutions, recognized the basic problem facing historians of medicine at medical schools was lack of time, lack of personnel, lack of funds. And again, that's a diagnosis that almost any academic would complain about in 2018. At the conference hosted here in 1966, Lester King was quite skeptical of George Rosen's enthusiasm for the field. From King's point of view, the basic problem was that we cannot seriously maintain that history makes better doctors in any practical sense. From his point of view, the goal of medical school was to make people better doctors. If you couldn't prove, and he didn't think you could, that history would make someone a better doctor, then there was no place for history at medical schools. And there have been a whole series of surveys over the course of the 20th century that documented the way in which history was losing ground as time passed. Cordell had complained in 1904 that only 3 out of the 14 schools he surveyed, not a very large survey, but only 3 out of the 14 had a course in history, something he identified as a shocking neglect and inexcusable apathy. When the History of Medicine Society surveyed the situation in the 1950s, it found organized historical courses at roughly half, at 47% of US medical schools. The Canadians were doing much better with history in an organized course in 100% of 7 medical schools in Canada. But the authors of the survey acknowledged that they really didn't know whether these courses were any good or not. And these numbers have tended to decline over time. As I said at the outset, there are very few medical schools now that have any required history in the curriculum. Where it does exist, it mostly exists as an elective. And the elective offerings, some of them are quite good, but they're often quite idiosyncratic based on the interests of the person who's teaching them. Now, one of the challenges the historians of medicine at medical schools have faced, especially since the 1960s, is new competition from fields who you think would be useful allies, but often have ended up as competitors for resources. And that's medical ethics and medical humanities, both of which were new fields in the 1960s. So both of these organized practices, again, obviously people have been interested in medical ethics for a very long time, but a discipline of medical ethics first emerged in the 1960s in response to a series of crises or perceived crises in American medicine and healthcare, especially with the advent of mechanical ventilators in the early 1960s. You start to see people increasingly concerned about the overuse of medical technology and that new technologies had created a crisis of value in healthcare. Patients increasingly complain the doctors were no longer talking to them or examining them, but were increasingly relying on radiologic and laboratory diagnosis. There were concerns about physician paternalism and debates about informed consent, which was gradually emerging as the new standard of practice in the 1960s. And then there were a whole series of exposés about research misconduct by physicians, which did little to enhance the reputation of the profession. One of the unifying themes in these critiques was that physicians had somehow lost sight of that their patients were actually people who deserved to be treated with empathy, compassion, and respect. So medical ethics promised a seemingly straightforward solution to these crises. Teach doctors to think more rigorously and self-consciously about questions of ethics and value and behavior, which is an excellent idea. It has become a huge enterprise. NIH, like every other institution, has a major office that reviews all research protocols. You cannot do human subjects research in this country without running it through an institutional review board and having medical ethicists weigh in about what you want to do. Every hospital in this country now has an ethics consult committee of some sort or another that's available to provide consultation on questions of clinical practice that seem to have been ethically charged. Medical humanities also took shape in the 1960s. It hasn't gotten the same kind of institutional embedding in hospitals and universities that medical ethics has gotten, but it has gotten traction more so in the United Kingdom and Canada than the United States, but it is present in the United States. The field, again, the exact form that medical humanities takes varies a lot from institution to institution, depending on the faculty that are there, but has been a mix of ethics, history, law, literature, philosophy, religion. And the unifying theme for many medical humanities programs is to help students understand questions of value and meaning, not simply through philosophy in the way that bioethics might, but through any of these humanistic explorations of medicine and medical practice. And if you look at the many reviews that have been written of medical humanities and try to understand what contribution are they promising to the practice of medicine, you'll find people arguing that training students in the medical humanities can foster certain qualities of the mind. It'll improve how you think about medicine and medical practice. It enhances critical abilities, flexibility of perspective, non-dogmatism, again, that notion of hubris about the contingency of medical knowledge, and can also foster empathy and self-knowledge. As a result of the advent of both medical ethics and medical humanities, medical schools have now put those two groups in competition with historians of medicine for space in the curriculum, for faculty lines, and also for grant opportunities. There are a whole series of grants that used to be available exclusively for historians of medicine, whose mandate has now been broadened to include medical humanities and medical ethics, which greatly increases the competition for what is often a shrinking supply of these kinds of resources. And you can see the impact of this in the most recent survey. While 51 of the medical schools in North America had some evidence of history, 66 offered something in medical humanities, and 126 had a formal curriculum in medical ethics. So there has been a sense, certainly for the 20 years that I have been part of the profession of history of medicine, that there was a crisis in the field and that we were losing ground on a variety of different fronts. And the question was what to do about it. So in 2013, shortly after arriving at my new job at Harvard, trying to figure out what would be my mandate in that position, I started to do a survey of the field and came across all these proposals, these arguments that had been made for the contributions that history of medicine could offer medical schools and universities. And I ended up not liking many of the suggestions. It wasn't that I thought any of the past suggestions were wrong. I just ended up thinking that these were not the strongest case that you could make for history. And if you wanted to reverse the losses that the field had experienced, you needed to have a very strong case. And after talking informally with several of my colleagues, it turned out we all felt the same way. And so I decided to host a workshop at Harvard in 2013 to try to figure out what we could do about this. So I invited colleagues from medical schools throughout the United States and Canada to brainstorm about the challenge and possible solutions. One thing we all realized, and most of this had come from our experiences teaching medical students, is that medical students are often very pragmatic. They're presented with a flood of knowledge from their core faculty in the basic sciences. They're trying to figure out how to actively triage their time. What should they be studying? And time again, the question that they come back to is this on the board exams, which is sort of the pragmatic expediency that most first-year medical students have to deal with. Some of them will be thinking about the underlying question, will this help me be a better doctor? But I think really the question that drives most of this is, what do I have to do to get a good score on step one, which is unfortunate. And then medical school deans are often very pragmatic in that they have everyone in the world comes into their offices and wants more time, more grants, more space, more laboratory for whatever it is that they happen to do. And so the medical school deans are always telling people, no, you can't have that. And if you want to convince them that they need to invest their limited resources in your endeavor, you have to give them a very concrete reason why it is that you will add value to their institution. And saying that you will foster humility amongst their students might be true, but it hasn't proven to be a very compelling, persuasive argument. You have to do more than just promise that you'll produce more professional and students with a better perspective. So as a result of these 2 days of arguments amongst ourselves, we ended up reaching a pretty good, strong consensus amongst the group that historical analysis can contribute to medical education in exactly the same ways that anatomy, biochemistry, pathophysiology, or anything else can, as a fundamental component of medical knowledge, not as an attitude towards medical knowledge, but as a fundamental component of medical knowledge itself. And so our strategy was to develop a series of specific claims that we felt have self-evident plausibility and relevance. And I'll give you some examples and then I'll show you the whole list. So the first one, the burden of disease changes over time. A thorough understanding of disease includes knowledge of the non-reductionistic mechanisms that can account for these changes. In other words, the social determinants of disease. And our feeling was there was no way you could possibly object to any component in that claim. It is a clear empirical fact that the burden of disease does change radically and often quickly over time. The top 10 causes of death now are very different than they were in 1850. And if you try to account for these changes, you often end up with a very particular kind of explanations. Now, this becomes a complicated issue in science policy and politics. But for a variety of reasons, institutions like NIH invest heavily in certain kinds of medical research, especially research that emphasizes the molecular roots of disease. And there are interesting explanations for why that has been the focus of effort here for the past 50 years. And as a result, the scientists do work where the funding is. The science journalists write about the work that the scientists are doing. And as you end up, if you were a random citizen reading the newspapers to try to understand what was important about disease, you end up with a very skewed view of the world. You'd think that genetics runs everything because that's the only thing that gets covered in American science newspapers because that's where most of the research funding is. And so I've realized, talking to both medical students and undergraduates, that they often have these very bizarre explanations for how to account for the changing burden of disease, where they assume that it all must be genetics because genetics is all they ever hear about in high school or in college. And I have even had students say with a straight face, present them with a graph produced by the CDC showing the increased prevalence of obesity in this country between 1970 and the present. Depending on the population, has doubled or tripled over the past 40 years. And I'll say, how can you account for that? And the first explanation that most students will give is there must be genetic change in the human population. And you'd say, well, why would you possibly think that? And they can't answer that question because there is no reason you would think that there's been substantial genetic drift in the human population in the past 40 years that would lead to a tripling of the prevalence of obesity. It's just that genetics is the reflexive explanation for everything. Or if you were to say, if you show them the very famous graph produced by Thomas McCune of the decline of tuberculosis in Western Europe between 1850 and 1950, you'll say, well, how can you account for the control of tuberculosis? And people will say antibiotics, because antibiotics are wonderful, wonderful things and they get very good press coverage. But it turns out in that setting, in Western Europe and North America, antibiotics had very little to do with the decline of tuberculosis. And so people have all of these mistaken impressions about the factors responsible for disease change over time. And that creates an interesting opportunity for historians to say, well, no, your initial thoughts are not correct. We can show that. We need to think more seriously about what is it that determines the burden of disease experienced by a population. And you can make very strong arguments, and I'll come back to one at the end. The various social factors are much more important, or public health interventions are much more important, or at least equally important. And if you are a medical student who's going to claim that you understand what disease is and how disease works, your understanding of that disease needs to include these kinds of historical insights to account for why patterns of disease change over time, because that will be very important, that kind of historical perspective, on decisions about policy and resource allocation. If you want to control a future burden of disease, it's valuable to have a sense for why the past burden of disease has changed. Or another one that, again, is an empirical claim. Health inequalities in both the burden of disease and in treatment access and outcome have persisted for millennia. History offers a central perspective about the causes of inequalities or possible solutions. This comes out of, in part, the first research project I had done that Jeff had mentioned about the problem of health inequalities between American Indians and the other populations in this country. And there's now a over 500-year record of colonizing Europeans recognizing that Native American populations had higher rates of disease. And the earliest of these claims go back to Spanish colonists in 1510. But for 500 years now, Europeans had always recognized that American Indians were sicker than the European colonists. You can go through and read these accounts, this 500-year history of what kinds of explanations have been given for this disparity. And they're very interesting patterns. But the other thing that you recognize is that the disparity has persisted even as the burden of disease has changed. And so when the Spanish and early English colonists in the 17th century were talking about the health inequalities, they were largely talking about acute infectious diseases, smallpox, measles, chickenpox, influenza, and others. By the 19th century, it was largely a function of tuberculosis. And by the mid-20th century, it was largely a function of heart disease, cancer, and mental illness. Now, for each of those moments, for the smallpox or tuberculosis or for heart disease, you can find people essentially making genetic explanations to account for these health inequalities. Diabetes is the most famous example, but for all of these major classes of disease, some scientist has published somewhere a claim that this health inequality exists for genetic reasons. And you can find an exactly parallel literature about African Americans. So again, ever since African Americans were enslaved and brought here, their health has been worse than the dominant white population in this country. The health inequalities have persisted even as the burden of disease has changed. And at any moment in that history, you can find physicians and scientists arguing that the particular disparity that was prominent at that time was genetic or hereditary in origin. And when you bring all these historical claims together, you end up in a very funny situation. You realize that you have made an argument that Europeans are genetically resistant to every category of human disease compared to American Indians and African Americans. And when you frame it that way, most people recognize that's just a preposterous claim. Again, there's no reason to think that Europeans should have some kind of uber resistance to all categories of human disease compared to other European populations. It's just not possible, and it reeks of sort of white supremacist rhetoric. And so when you put it together like that, people become very uncomfortable. And they wonder, how have they ended up with such an explanation that's patently implausible and intolerable in various ways? Well, what's the alternative explanation? The alternative explanation, again, is a social one. The other thing that has persisted for 500 years for American Indians and for 300 years for African Americans is persistent social economic inequalities. Those populations have always been poor. They've always had less access to resources. They have always been oppressed along different axes. And so that suggests a different explanation, which is that the persistent inequalities in wealth and power are what are generating the inequalities in health, regardless of what the prevailing disease happens to be. So if the prevailing disease is heart disease, if the prevailing disease is tuberculosis, the populations that are worse off economically are going to be worse off medically as well. And I think that's actually what's been going on. Third case, medical therapies and how their efficacy is determined change over time. Again, that's an obvious point. It'd be hard to do the math, but I assume that well over 99% of all medical therapies ever tried have been abandoned. The ones that remain are a very small subset of therapeutic effort. Good medical care depends on an understanding of the changing values and evidence reflected in claims of therapeutic success. There's obviously big business to be had in making the claim that this new therapy works. That's the fundamental question that all patients ask their doctors: will this treatment help me? It's the fundamental reason for which people apply to grants to NIH. I am doing research to find a treatment that will work. So the question is, well, what does it mean to say that a treatment works? Many people have a simplistic, intuitive sense. It's like, well, it makes you feel better. But as medical researchers have realized over the 20th century, that's actually a very subtle and nuanced question. There are many different ways to determine efficacy. You can look at symptoms. You can look at survival. Outcomes of therapeutic intervention often look very different from the perspective of the physician versus the perspective of the patient. And there's something important to be gained by looking very closely at how people have thought about therapeutics in a historical perspective and how they continue to think about it today. And you realize the various ways in which even something as robust as evidence-based medicine embeds within it a whole series of subjective value assessments that you need to understand if you're going to make progress in that enterprise. And I'll give an example of this at the end. And then a related claim: medical technologies exist as part of broader social systems. History shows that innovation is not always progress, that technologies have unanticipated costs and consequences, and why improvements are not always implemented. Again, this is just a simple empirical claim. You can choose your favorite example to illustrate these points. But there are many valuable treatments that are not well utilized. The most recent review of this question was published in, I think it was in 2003, in the New England Journal of Medicine, found that Americans receive on average 50% of what evidence-based treatment should recommend that they should be getting. I have asked the authors of that report to try to update it. Has anything changed in the 15 years? And they said the research involved in producing that study was so backbreaking that no one involved is willing ever to do it again. So we're stuck with this 15-year-old estimate. But most people in health policy don't think that number really has changed that much. A lot of patients are not getting the evidence-based treatment that they deserve. And unfortunately, the flip side is also true. An enormous amount of money is spent providing health care that isn't actually necessary for that patient at that time. There are a whole series of subtleties of this, but there was a report that got a lot of press last week showing that of all the patients who were prescribed narcotics, 30% of them, according to the medical charts, had no basis in the chart for a prescription of a narcotic. I suspect there were subtler things going on, but the claim that medical technology is overused is not a controversial claim in this country. And again, history can do much to understand or to show why this happens and what you can do about it. So we ended up coming up with 13 of these short one-line claims, and the idea was you could take any of these claims, go to a dean and say, look, this is what history has to offer, and if you phrase those claims very carefully, there's really no way they can say this isn't true or this isn't relevant. And if you are armed with a series of claims like this, you'll be able to be much more persuasive, and you can make a much better case whether to your dean or to the students that you're trying to teach. And so 4 of us got together and wrote up our results and published it a couple years ago in the Journal of History of Medicine. And again, as I've been saying, our claim here is that the specific arguments you can make about the history of medicine demonstrate the undeniable value of history to medical theory and practice. History does not just convey an attitude towards medical knowledge, recognizing contingency, antidotes towards hubris. Instead, historical analysis alongside molecular biology or pharmacology, makes fundamental contributions to our understanding of disease and therapeutics. So if you were convinced by this, the question is, well, how would you actually implement this in practice? What might it actually look like? So let me give you a couple examples of the kinds of stuff that we do in the curriculum at Harvard Medical School. We found Harvard Medical School does not have a course in history of medicine. So if you were a surveyor who was looking at the curriculum, you would conclude that Harvard is a place that does not have an organized course in the history of medicine. But that'd be a misunderstanding of how the curriculum works. I was well positioned during the most recent round of curriculum reform, and so I was able to embed history or historical perspectives in a series of places into the curriculum in ways that aren't advertised as this is the history of medicine lecture, but get people engaging with these questions and thinking about them in a serious way. And it's really not that hard to do. So one thing that first-year students often realize is the medical profession, and also especially the teaching faculty at most U.S. medical schools, is not as diverse as the rest of society. Since the 1990s, most medical schools in this country have been at least a 50-50 male-female split. Many medical schools have had a majority of female students now for a generation. Many medical schools have made great progress diversifying the student body. So now at Harvard Medical School, the entering class for decades now has been more women than men, more non-white students than white students. And yet the faculty, especially the teaching faculty, is largely a group of white men. So it raises an interesting question. And if you were to look at department chairs at hospitals, it'd be a similar situation. Incredible diversity amongst the medical students, interns, residents, and junior faculty. Very little diversity at the senior ranks of hospital departments. That's an important observation. The question is, well, why does it exist? What can you do about it? And it's a great topic for historical analysis. Harvard Medical School has its own sordid history when it comes to both race and gender. The faculty voted to admit African American students for the first time in the 1850s, and that was blocked by the students. The white students felt that having black students in the classroom would diminish the degree that they would receive, and the faculty caved in to student pressure. The medical school repeatedly wanted to admit women, but was blocked for a variety of different ways, first by students, then by faculty. It was only during World War II that Harvard Medical School finally went co-ed, and only because they could no longer fill their classes with men because all the desirable men had been drafted and were in war. So the only reason Harvard Medical School went co-ed was because of the contingencies of World War II. The irony there is the decision to do it was a day before D-Day. And people will joke if the committee meeting had been postponed a week, they might never have done it, because if they had known that D-Day was as successful as it was, they might have realized if they could just hold out one more year, they would have the men they needed and would not have had to admit women. Hard to know what would have happened, but those kinds of counterfactual questions can often be fun for discussion. Another one that has always been on students' mind, why do we have such a bizarre healthcare system in this country? Why is the United States alone of the wealthy countries in not having universal access to healthcare? Again, a great topic for historical analysis. If you want to approach health policy without wanting to bang your head against the wall, one of the best things to do is to approach health policy through the perspective of history, to understand why we have the system that we have, what are the various interests that have been influential. There are great sources that are available now to document the history of healthcare policy. One of the ones I like to use most of the students is this LP produced by Ronald Reagan back before he was governor of California. He was hired by AMA and a series of shadow entities to record a 10-minute audio recording against socialized medicine. It has now been digitized. It's available online. It's worth a listen if you haven't heard it. It's really an amazing piece of political rhetoric that feels very relevant today because many of the arguments he made 50 years ago continue to get made against universal health care. If you're interested in this question of, what determines the uptake of new therapeutic innovations, there are a million case studies that you can use. One of the ones that's most alarming for students is the history of anesthesia. It's fun for us because this is a bit of local history. As many people are aware, the first surgical demonstration of ether anesthesia was done at Mass General Hospital in 1846. And if you look at what happened over the next 10 years, there was very quick enthusiasm. News of this spread to Europe very quickly. It was the first case of a medical innovation crossing the Atlantic Ocean from west to east. Obviously now happens all the time, but this is the first thing that the Americans discovered that was picked up by Europeans. Part of the reason that anesthesia was picked up so quickly in Europe is that these drugs had been well known amongst medical students for 50 years. Ether and nitrous oxide were both used as party drugs by medical students in the first half of the 19th century. It just never occurred to anyone to use them for their patients as part of surgical anesthesia. So understanding that half of the story is both fun and alarming for the students. And then also if you look at the uptake, even though anesthesia became popular in some sectors very quickly, it wasn't true everywhere. And so anesthesia was not used at Pennsylvania Hospital, now the University of Pennsylvania, until 1853. So there was a 7-year gap after ether had been demonstrated in Boston before it was ever used in Philadelphia. The explanation of that in part has to do with the longstanding medical rivalries between Boston and Philadelphia. But it's a very interesting story to explain how and why something like anesthesia was or was not used in different times in different places. And you can also do much with history as part of an exploration of medical ethics. We now have a very elaborate processes in place that govern research, especially human subjects research. Most people who do medical research are filled with dread when they think about IRBs and the annual certifications that you have to do and everything else. And the question is, why do we have this system in place? What values are embedded in it? How could it be changed? What could we do to make this more burdensome? Or, if you recognize the reasons why this bureaucracy was imposed, it often makes you more tolerant for the bureaucracy that exists. And again, there are terrific cases of various research scandals and non-scandals over the 20th century to get students to think seriously about the kinds of values that are embedded in human subjects research. And as I said at the outset, history can also play a role in thinking about medical research and practice, not just these questions of what you want to teach students. So as I said, over the past decade or so, several treatments that had been dabbled with in the early 20th century and then abandoned have been revived in certain quarters, which raises the obvious question, is this a good idea? Now, no one stops to ask the historians, do they think this is a good idea? They've gone ahead and done that. And so the question is, well, had they gotten that historical consult, would the outcomes have been different? And the answer depends on the cases. So one of the ones that has come up recently has been serotherapy. So serotherapy is using antibodies therapeutically against infectious diseases. Now, obviously, one of the great accomplishments of the 20th century medical science was the development of antibiotics and antivirals that have led to, I don't know the right adjective to use, not the total control, but the substantial control of infectious diseases and the potential for near total control if these technologies were utilized as widely as they could be. Between antibiotics, immunizations, antivirals, we have tremendous power over many of the great infectious diseases. But by the late 20th century, a series of problems had materialized. It has been difficult to develop antiviral medicines for a variety of reasons. Viruses are much trickier to do than bacteria. And so there are many great viral pathogens, influenza, Ebola, and others, for which there's not a great treatment as there is now for HIV. And then many bacteria have been busily developing resistance to antibiotics. I was at WHO archives last week, and they had a big placard out at the main entrance. Our time with antibiotics is running out, which is obviously a fearsome thing to worry about. Well, the question is what to do. All of these recent developments have led to a resurgence of interest in the early 20th century therapeutic system, the serotherapy. And the idea as it was developed, especially in the 1920s and 1930s, was to collect antibodies from people or other creatures who had been infected by a pathogen. And the way this was operationalized by most public health departments was to have large stables of horses or large collections of rabbits who you would infect with a pathogen. They would then develop antibodies. You would then harvest the antibodies from those rabbits and horses and use them therapeutically in humans. It's obviously a much more cumbersome system than giving someone an antibiotic. But it turned out for certain diseases in certain contexts, it was a hugely effective approach. Pneumococcal pneumonia had been considered one of the great scourges of early 20th century medicine. William Osler named it the captain of the men of death. It was often described as an old man's friend because if you were sick and chronically ill, one of the things that you could hope for that you would have an easy death from a rapidly progressive bacterial pneumonia. But with the advent of type-specific anti-pneumococcal serotherapy produced in a very particular way in the early 1930s, in the 1920s, 1930s, you had very good control of pneumococcal pneumonia in hospitals. Doctors were so pleased with the power of serotherapy in this setting that when the first alpha drugs, and then even when penicillin became available in the late 1930s, 1940s, there was skepticism about whether these drugs were needed. And so if you look at some of the early trials of antibiotics, they were often done in addition to serotherapy because doctors felt it was unethical to withhold serotherapy, which you knew worked, from patients while you were testing these newfangled antibiotics. And so these drugs can work very well in the right setting. And if you do careful historical analysis, there's a great book about this by my colleague Scott Podolsky. Again, the work for this book was funded by one of the NLM historical research grants. You can understand what is involved in getting serotherapy to work well. It's not a simple thing to do, but with the right design of a system and the right resources, serotherapy can work really well. With the outbreak of Ebola in West Africa, many of the therapies that were tested then and since have essentially been serotherapy, collecting antibodies from people who had survived Ebola. And so this kind of approach remains alive and well in certain areas. Now, my own research, as Jeff said, recently has been about the history of cardiac therapeutics. In the early 20th century, coronary artery disease became the leading cause of death, not just in the United States, but now worldwide. In every country in the world, except in some patches of sub-Saharan Africa, coronary disease is now the leading cause of death, over 10 million deaths a year. Doctors and surgeons obviously were quite interested in developing treatments for this. Many of them recognize the disease as a problem of supply and demand. As atherosclerotic plaques form in the coronary arteries, it impairs the ability of the vascular system to provide blood and oxygen to the heart. And when you have a heart that's dealing with an inadequate supply of oxygen, you can get angina, chest pain, or you get heart attacks or sudden death. Surgeons tackled this problem with incredible creativity and innovation, trying to figure out how to do one of two things: either reduce the heart's demand for oxygen, which involved cutting the sympathetic nerves or removing the thyroid gland, trying to decrease the overall metabolic burden on the heart, or trying to figure out ways to provide new blood supply to the heart. And again, I said they were very creative in how they would do this. They would take arteries from parts of the body and embed them into the wall of the ventricle itself. They would wrap the heart with various tissues, whether muscle or lung or spleen or omentum. And they would do things like they would sprinkle the surface of the heart with asbestos in hopes of producing scar tissue, the idea being that blood would flow through the scar tissue into the myocardium and provide a significant new supply of blood to the heart. As one skeptical editorialist in the New England Journal of Medicine wrote in 1957, the implantation of tissues bearing vasculature, the plunging of a pulsating and bleeding artery into myocardial tissue, the creation of pericardial adhesions, and attempts to augment by irritating epicardial substances intercoronary anastomoses have placed the myocardium in a class by itself as an object of surgical assault. Now, all of these treatments would be high on people's lists now of like the craziest things that surgeons did in the 20th century. But the thing that's amazing about this, if you go back to the literature at the time, surgeons often published very robust outcome studies of these procedures. These surgeons were often very careful researchers. They were very savvy about placebo effects. They were very savvy about how dangerous it could be to rely on a subjective assessment like angina if you're trying to figure out whether or not a patient has survived. And so they tried very hard to produce objective evidence of the efficacy of these interventions. And so I have a video that I want to show you of a woman who was treated by Claude Beck, a prominent surgeon in Cleveland. And so what you'll see here is the patient before surgery, describing how she's feeling. You'll see a clip of she and her husband describing how improved she was after the surgery. And then I have a clip of her intraoperative video so you can see what the surgeons actually did. And these have both been excerpted. The actual video itself is much longer.
I have pain in the chest and I am short of breath. Exertion brings on pain. I am limited to only light housework. My operation was done 1 year ago. I have had an excellent result. I have no anginal pain and take no medication whatsoever. I do all my own housework.
Since the operation, my wife is a new woman. The gloom of weakness, pain, and suffering was always present in our home. Now a new life has been restored to her, as well as to me and my family. She enjoys social events, she likes to dance, and she likes to wear pretty clothes again. She lives a normal life.
The entire surface of the heart is gently abraded. The coronary sinus is narrowed. Asbestos powder is sprinkled over the entire surface of the heart. 2/10 gram of asbestos powder is used. It is a mild inflammatory agent and produces collaterals.
Now, obviously, much has changed since the early 1960s when this video was created. And this was before asbestos was recognized as a cause of mesothelioma and asbestosis. So the cultural valences of asbestos were very different then than now. And if you listen carefully to what the husband and wife were saying, many of their claims of efficacy involve very specific domestic expectations of women. You could determine the health of a woman by her ability to do housework, to host cocktail parties, to wear fancy clothes. Some of my students, when I've shown them this video, have said when the husband says she likes to wear fancy clothes again, is that code for saying they have resumed sexual relations? It may be, there's no way of knowing, but all of these things involve very coded language. And this is just one example. I could give you example after example after example of very specific and sometimes compelling efficacy claims being made about treatments that we would now consider bizarre, toxic, totally pointless. And funded by National Library of Medicine, I've nearly finished a book that explores the history of this and what you can learn about the therapeutics by taking seriously some of these strange surgical procedures that were popular before the 1960s. So you can imagine my surprise in 2015 when the New England Journal of Medicine published a randomized clinical trial, sham-controlled, of one aspect of that procedure that you just saw. So what Beck did during that operation was he stripped the epicardium off the heart, sprinkled it with asbestos, and then put a constricting band around the coronary sinus. That coronary sinus restriction was something that had been tried in the 1930s to the 1950s. It never made any sense exactly why that would work. So the coronary sinus is the vein that drains the myocardium. So blood comes into the heart through the coronary arteries, goes through capillaries, gets gathered from the capillaries, from the coronary sinus, and then drains back into the atrium of the heart. And so it wasn't clear why restricting flow through that coronary vein would treat coronary artery disease. People had all sorts of intuitions. Many of the ideas were a bit half-baked. It was tried. Eventually they realized it didn't help, and it was abandoned. For reasons that aren't totally clear to me, that idea was revitalized in the early 2000s, not to do it surgically, but because now you could do it with a cool catheter-based technology. And so you can see here, they have this neat-looking hourglass-shaped coronary stent, not a coronary artery stent, a coronary vein stent that you can put in through a catheter and achieve a partial restriction of the coronary sinus. So it was a cool new technology that allowed them to do more easily something that surgeons had tried to do through heart surgery in the past. I was asked by the journal to write a commentary on this to accompany this article when it was published. And it was very tricky to do because the journal had decided to publish this randomized clinical trial, which in a way they thought this thing made enough sense to make it worth publishing in the New England Journal of Medicine. And I was coming at this as a historian thinking like this was the stupidest thing ever. But I couldn't say that because if I said that, that would then be casting doubt on the judgment, the editorial judgment of the journal that had decided to publish this trial. So it was a very delicate balancing act as I was trying to write up my commentary on this. But just because you can do something more cleverly now than you could 50 years ago doesn't mean it's a good thing to be doing. The question that they should be asking is, well, did this ever make sense in the first place? And if it didn't make sense in 1950, it doesn't make sense now, so you shouldn't do it even though you have this cool new hourglass-shaped stent that's probably making someone a lot of money. And sure enough, now there have been a whole series of articles about this coronary sinus reducer that have been published. And if you look at the sections of these papers where they try to explain the physiological rationale, it's completely incoherent. they really have no idea why this works, and many of the claims that they make are internally inconsistent with each other. But they say, but it works. If you look at the patients report feeling much better. Their angina is relieved. And as someone who's writing a book about the history of treatments for coronary artery disease, the most obvious answer from the history of these treatments is that anything you do to a person will relieve their angina. That has been shown literally thousands of times over the past 100 years. And just because a treatment reduces angina doesn't mean it's actually good for the patient. It's a complicated issue. But anyone doing this research ought to know the problems with relying on subjective assessments of coronary artery disease. And yet now there's this whole literature and a device industry making these devices that's based on what any historian would recognize is an unreliable claim. So I hope the bottom line here is clear. There are many ways you can make the case for why understanding the history of medicine can offer essential insights into the theory and practice of medicine. There's important knowledge about both disease and therapeutics that is best taught through history. And you could make similar arguments about healthcare policy or ethics or many other areas. There will, of course, be skepticism and resistance. How could history be as important as biochemistry or pharmacology or anything else? But just because there's resistance doesn't mean that you should abandon these goals of restoring history to a useful place in the medical curriculum. It just means that historians and physicians interested in history need to work carefully to strategize and deploy the best arguments to make the case for history well. And if you do, it should be possible to find ways to reinsert history into the medical school curriculum in ways that I think in the long run, both physicians and their patients will benefit from. And so I'm happy to take time for questions. Yeah, yes, I'm supposed to ask people to come up to microphones.
No, use the mic. We have microphones.
Excellent.
So how did you structure your commentary for the coronary vein stents?
I had a whole lot of very specific language in the first draft. And when I went back and forth with the person who edits the perspective section, it was just clear that I wasn't going to be able to be totally direct. So what I end up saying is it's mostly a historical piece about the efforts of Claude Beck, the surgeon who produced those videos, to say this is what he tried, these were the obstacles that he had. Really the key issue in the end was that there was no credible physiological rationale for why the coronary sinus restriction ought to work. And mostly leave it up to the imagination of the reader to fill in the blanks and be skeptical of it at present. It's very hard to know whether those sorts of interventions have any efficacy. When I did a recent search, I was quite pleased to see that there was a more recent study. So I was commenting on a 2015 study. There was a big study that was published just this past April, again, showing how wonderful this treatment was and how well it relieved people's angina. And some cardiologist who's a blogger wrote a blog post about this 2018 study where he said, this makes no sense at all, and then cited my perspective. So at least someone read between the lines. So, yeah.
Thank you so much for your talk. It was just really rich and wonderful. I have a question. Some of the early examples that you gave about the claims, what claims you could make, and sort of the why behind why we are where we are. Yeah. I'm curious if you've partnered with some of your behavioral economist colleagues, those who are, getting into the sort of the sense of a nudge or to change, because you clearly can present the evidence and kind of almost lay a pathway out for impact on present day, particularly in public health.
And so collaborate with them to try to figure out ways to actually be more persuasive in making this happen?
Be more persuasive or put the nudge in place that moves people in a certain direction without having to even particularly persuade them.
Yes, so I haven't. It's an interesting question. If you wanted to go forward to try to make the transition, so we published this article, and the question, what's the efficacy of publishing an article? Many people will say not very much. You actually have to then follow through, and you have to work harder to actually make your ideas, or to put your ideas into action. So how would you figure out the best way to put this into action? It's a tricky thing. As I said, the medical schools are facing a zero-sum game in terms of the number of hours that you can expect students to do work. There are many complaints from undergraduate and medical school faculty that students' study skills just aren't what they were 20 or 30 years ago. So it used to be, when I was in college, you could put people in a lecture and expect that some of them would learn something from that lecture. Now, whether or not they actually did is not clear, but much pedagogy was based on the fact that you could put someone in a room for an hour, talk to them, and have them absorb something of what you said. Or that you could ask them to read something, like read a book, and then learn something from that. And it's quite clear from talking to students, as I said, both undergraduates and medical students, something has changed. I think it's changed for the worse. And so a lot of students will now say, if they go to a lecture, they just tune out. They are unable to listen to a lecture for an hour. Much of that has to do with, 30 seconds into the lecture, they check their social media status. And once that happens the lecture is ruined for them. And if you look at course evaluations, they will often say, any reading longer than something, 2 pages, 5 pages, 8 pages, should be dropped from the syllabus, because if someone can't express their ideas in that length, it's not worth reading, which is a very strange attitude towards knowledge. And they'll say, well, you always require too much reading. It took me 5 hours to do the preparation. That's just not realistic. So I've had students say it took them 5 hours to read 30 pages. So then I'll sit them down and say, like, what on earth were you doing for 5 hours? Like, if you had read this out loud and slowly, it wouldn't have taken you 5 hours. And so it can be very difficult to figure out when you're dealing with that kind of resistance, what can you do? Our approach was to do this subtly. There are great books that historians of medicine have written. You can't ask medical students, and it's even hard to ask undergraduates to read something at book length. It's clear that medical students are totally interested in doing case-based approaches, as developed repeatedly by medical innovators, that case-based approaches can get through student thinking in a variety of useful ways. And so that's the option we've gone for. We present them with a series of cases. The case asks the question, why is the HMS faculty so undiverse? And then it gives them the chance to brainstorm. And the question is, well, then how do you equip them with the knowledge needed to have a useful brainstorming session about this? And we've ended up sort of custom writing a whole bunch of curricular materials, which I'll be happy to share with anyone who's interested. Just email me and I can send you what we've done. Trying to navigate this line between the impaired attention spans and the need to provide knowledge as a basis for informed discussion. And I don't know if we're totally successful, but again, I think by doing it subtly, which is, again, what the behavioral economists would say. They'd say, if you want people to choose fresh fruit at a cafeteria, put it near the cash register, present it in an appealing way, have that set as the default. So we were able to embed historical content essentially as the default in different places in the medical school curricula and present it in a palatable way. And that has been successful. It's not an answer that can work everywhere. 2 summers ago, I was part of a delegation of faculty from the US that went to talk to medical school faculty in China. So China perceives a massive crisis of medical professionalism, similar problems in India. There are very high rates of assault against doctors. China has decided that one of the solutions to the crisis of professionalism is to mandate teaching in medical humanities at all medical schools in China, which I'm supportive of. I'm not sure if that's going to solve the problem. I think it's sort of a good idea being done for the wrong reason. But the question is, well, how do you do that? They don't have the faculty required to teach medical humanities at every medical school, and some of these schools are quite large. So I gave a talk similar to this one, described what we had done. And the guy said, well, a guy came up to me afterwards and said, well, I have a problem. I'm responsible for teaching medical humanities at my medical school. I'm the only person on the faculty who's going to do this, and we have a class size of 2,000 students. How can I teach, because all the teaching we do with the history at Harvard Medical School is small group discussions. He said, I can't do a small group discussion with 2,000 students. I have to do lectures. How can you adopt this approach to lectures? At which point my brain just seized up at the thought of having to try to teach anything in a lecture format to a group of 2,000 students. And so, all of these things that whatever nudges you're going to do have to be done locally with awareness of what resources you have access to, what opportunities do you have in the curriculum, what kind of dean do you have, and what kinds of arguments will be persuasive to that dean or not. And so it's okay, all politics is local, and you just have to be savvy. We've been quite lucky in the current administration at Harvard Medical School. The dean of medical education is a philosopher and ethicist, so he's very sympathetic to all of this. And the dean of the medical school is a stem cell researcher who, over his career, has recognized that ethics actually has an important thing to say to medical researchers. And so we have the good fortune to be in a very sympathetic environment. That's not always going to be true. The 2 deans ago was completely uninterested in any of this stuff. And so the situation we have now is good, but I'm aware that it's not going to last, or it's at risk of not lasting forever. Yeah.
Yeah, thank you. Great talk. Thank you very much. I'm wondering if in this conversation about how much is on the plate of medical students in medical schools and what bandwidth and time do they have to add a discussion of history, is there a possibility that looking at the whole academic career of a doctor, that they have 4 years before medical school when they're able to take a very broad brush on their experience. So certainly they're pre-med and they're taking pre-med courses, but generally as part of their university study, they're required to take courses in English and writing, courses in history, courses in other disciplines that in a lot of ways could add to their efficacy as a doctor. So has there been any thought to that as well?
Yeah, and then the other place, the question that comes up is, what about postgraduate medical education? And so yes, so if you're going to try to improve the knowledge base of practicing physicians, you have a huge sort of series of different opportunities to try to do that. And the appeal of doing it at the medical school level is that's, of all of these opportunities, that's the most regimented one. The AAMC keeps pretty close tabs on what medical schools are doing. In theory, they have the power essentially to throw a switch, and AAMC could mandate history of medicine teaching. They've essentially mandated medical ethics teaching, and now all medical schools teach medical ethics. And so it's one of the very few places in American education where there is that kind of command economy, if you could do it. The current administration at AAMC is actually quite sympathetic to this. The problem is that if they were to put a mandate, it would cause a problem for the majority of U.S. medical schools that aren't staffed to do it. So that last time my colleagues had a long discussion with the leadership at AAMC, the issue wasn't whether or not this was a good idea. They just said, of the 180 some odd medical schools in this country, only about 30 of them could do this well. And so we're not going to put a mandate on medical schools to teach history when they have no historians on their faculty. Now, there's also leverage on the pre-med curriculum in that everyone has to take the MCAT test. In 2015, the MCAT now requires a section on social behavioral sciences. I think it's sort of a grab bag category. It has created a problem at colleges. The students now say, okay, I know that if to take the MCAT, I need to take organic chemistry, general chemistry, physics, biology. Where's the course that prepares me for the social behavioral section of the MCAT? Many colleges have created one, and it's a hodgepodge course that does a little psychology, a little sociology, a little philosophy, a little history. Many schools first don't like the idea of teaching to the test, so don't want to create a course specifically to train students to take a standardized test just because they feel that's wrong in some way. Or that would require getting a sociologist, a psychologist, a historian, an anthropologist, an ethicist somehow to agree on what it is that they're going to teach, which is possible, but not easy. And so as a result, the students then sort of choose the sort of smorgasbord of activities, trying to figure out what to do, and then they just buy the review book, which tells them how to study for that test. So there are great opportunities to do this in undergraduates. And various schools have dabbled. So Sinai has a program that makes it easier for people who are doing non-science undergraduate careers to get into medical school. And now they've been doing outcome studies to show that the people who have non-traditional backgrounds do just as well. In some respects, have higher quality of life. The word is getting out. I teach a undergraduate medical ethics and history course. Of course, it takes a historical approach to medical ethics. And that recently the enrollments had ballooned, which was useful and gratifying. I was talking to students about why this had happened. And the answer that came back was that many medical school admissions committees now are asking students ethics questions as part of the interview process, based on the idea that somehow if you ask people ethics questions, you get a sense of their thinking and moral fortitude or something. And so the word on the street at Harvard is that my course is good preparation for medical school interviews. Well, I'm happy to have good and big enrollments. That's not the reason you ought to be taking this course, to prepare you for this very artificial environment of medical school interview. But certainly undergraduates have much more bandwidth. And I mean, since I go back and forth between teaching medical students and undergraduates, I can actually teach the undergraduates a much more sophisticated version of all of this than I can teach the medical students. And so this weird thing to be teaching the more advanced professional students a watered down version of what I teach college freshmen. But that's how it goes. Within the medical school, there's interesting about, should you teach students in the first and second year before clinical work, or should you teach after clinical rotations? I'm increasingly in favor of trying to get this kind of teaching done after the clinical rotations. Telling first-year students that the healthcare system is broken, you need to understand history so you can understand it, doesn't resonate with them. But if you see students after 12 months of intensive exposure to medical bureaucracy, they are then much more interested in these questions. Or if you talk about a problem like non-compliance and the ways in which physicians often wield non-compliant as a judgment against their patients in a way that disrupts patient-doctor relationships, first-year medical students will say, I will never be judgmental of my patients. Third-year medical students no longer have that confidence. And then there are also opportunities to do it for postgraduate medical education, teaching at medical conferences of various sorts. So there are lots of opportunities. Yeah?
So in one of the cases you brought up, you mentioned if they had gotten a historical consult.
Yep.
So can you give us a sense of, how often historians are consulted in ongoing biomedical research? Is this something that happens?
My sense is that it never happens. Yeah, or it may have happened. I'm just not aware of any examples. Trying to think, is that really true? Some of the people who were involved in the serotherapy stuff were aware that there had been a prior history of serotherapy. But I don't think their engagement with the history went any deeper than it's sort of reassuring that this happened. That it created sort of a market for the historical knowledge. And so when serotherapy started getting discussed in the midst of the Ebola epidemic in 2015, one of the editors at Annals of Internal Medicine, Deborah Cotton, who's an amateur historian, said, serotherapy, I know someone who knows something about this. Let me call Scott Podolsky. And so she had Scott write essentially a Cliff Note version of his book, which was published in Annals, and that got widely picked up. It was covered in the New York Times. And so there are cases when the people have gotten there on their own. They've realized that there's an opportunity for historical knowledge, and that historical knowledge then got traction. But again, it was done after the fact. I can't think of it when it was done prophylactically. And in my interactions, especially with interventional cardiologists and to some extent with cardiac surgeons, for a variety of reasons, there's a lot of resistance to engagement with the history of these fields, in part because they see any kind of historical analysis as a critique. And it's very easy as a historian to be critical of what's happened in the past. And most of what passes as historical analysis is a critique of what went wrong in the past in order to do something better in the future. And so I can understand why current practitioners of those fields often have a defensive response to that. The depth of the defensiveness that I've seen in interventional cardiologists is really stunning. I once gave grand rounds at one of the hospitals in Boston that the title of the talk had overuse and angioplasty, both words appeared in the title, not adjacent, but they were both in the same title. And even before I gave the talk, I got about 20 emails from one of the interventional cardiologists writing a critique of the talk that I had not yet given. And initially, I tried to engage with them in a conversation, and this was before fake news had become a big thing. I have a much better understanding of this conversation now than I did at the time. I tried to establish a historical common ground. So I said, look, here are 4 things I think we can agree on. That there have been controversies about the appropriate use of angioplasty. There have been accusations of financial conflicts of interest, and there are a couple of other things, both of which are just straight empirical comments. It's not a question of interpretation, but there has been controversy about these things. He wouldn't even accept those 4 claims. There was 0 common ground to have a conversation about this, which to me is really, really interesting. Why are these groups so defensive about this kind of history? I once got criticized by a very senior cardiac surgeon at Mass General who said, look, I understand why you're critiquing things that cardiac surgeons did in the 1960s. Like when open heart surgery got going in the 1960s, surgeons paid very little attention to the neurological complications of heart-lung machines, which it turned out at the time were substantial. And there are interesting things to be learned by studying that history. And so, as I wrote in one of my books, there was this long period of time in which doctors were not paying attention to the complications of these devices, and it's likely the fact that patients were harmed as a result of this. So the surgeon said, well, by telling people now that surgeons did a bad thing in the past, what you have to understand is that people often aren't very sophisticated in their historical thinking. People are going to mishear your critique of past surgeons as a critique of current surgeons. They're going to be scared away from surgery, and they're going to die as a result of your historical work. And the argument basically was, you shouldn't bring up bad things that happened in the past because they could scare or confuse people in the present. And if you believe that argument, there would be no history. And I put up this quote. This is a quote written in 1639 about the value of history that was quoted by Osler in 1902 as one of his reasons why history was so important. And obviously the language is a bit foreign, but the basic idea here was that by studying history, you can learn from the mistakes of the past and get more wisdom and experience that you would have based on your own life experiences. I'm totally convinced by that, and so I was horrified to hear the surgeon saying, it's best just to ignore what happened in the past because the past can harm the present in some way. And so I said, well, I just have a diametrically opposed vision of that. Like, we need to understand the mistakes in the past so that we can do things better in the present. And again, it made no progress at all trying to convince him. And so as a result, I think most people now would say there are very few places in which history would be obviously relevant to a biomedical researcher. And I just don't think that's true. And I think if historical training of doctors or of biomedical scientists was better, there would be more recognition in the ways in which there's a common dialogue that could be had. People might consult people better, and many people would benefit. One example, I think, of a successful collaboration, but again, I think it was after the fact, was in the 1980s, as the AIDS epidemic was starting to get into full swing. The person who became my advisor, Alan Brandt, who was then a historian who had just finished a book on the history of syphilis, which was published in 1982, realized that he was, as a now historical expert on venereal disease control and sexual mores in this country, he would have something to say about the AIDS epidemic. And he was quite successful in getting traction. He was able to publish in Science, in the American Journal of Public Health. He gave talks at most medical schools in the country about the historical lessons of syphilis to HIV. Things like premarital screening is pointless because the population who submits to premarital screening is not the high-risk population for either syphilis in 1910 or HIV in the 1980s. He now has to back away from some of his arguments at the time. He had said, well, look, when penicillin was developed, people thought that penicillin would be a cure-all for syphilis. Turns out to have been much more complicated than that. Syphilis persists. Syphilis has actually been on the increase over recent decades, despite the advent of curative antibiotics. his phrase was, there is no magic bullet. These things are complicated social epidemics. A single solution, technological solution isn't going to be a huge asset. And so he said the same thing would be true in HIV. He said, people are going to look for magic bullets for HIV, but they're just not going to be that effective. But HIV is a case in which protease inhibitors were really, really effective. They haven't solved the problem. The incidence of HIV has been totally stable. The U.S. has 50,000 new cases every year now, 50,000 new cases every year in the 1990s. So there's been no decrease in incidence in HIV in this country for 30 years, but it's very little mortality. And so that is a case where the historical consultation made sense at the time. In retrospect, probably wasn't totally accurate, but now you could write a revised one. What are the conditions in which a magic bullet-like therapy works or doesn't work? So I think it's a missed opportunity. There are lots of good things that historians could offer if they were able to have good conversations with the researchers, but there are many sources of resistance. Excellent. So if there are no more questions, I'm happy to stick around and talk to anyone who wants to follow up. Otherwise, thank you for your attention.